Board bombs.
Welcome back to another episode of EM Board Bombs, where Dr. Briggs is already laughing at me, but here we are.
It's because you're on Mountain Time. There was a delay in the countdown for you.
I guess so.
It occurred a few seconds later. You're 2 hours behind me.
Yes, it's afternoon for me. It's evening for you, but we're both here, ready to drop some knowledge for our loyal listeners.
Yes.
Yeah. Who are
the sun never
us.
sets on the Board Bombs empire.
Yes. all across our many time zones, which
Yes.
Dr. Hussein is in one of these time zones.
Yes, we'll let you guess.
Yeah, who knows?
Yeah.
Maybe he was at the Grammys. Maybe he's even further away. We don't know. Promoting us somewhere, I'm sure.
Yes, of course.
So thank you for joining us, for every question stem and 10 to 30-minute episode, if it's an episode with me, probably. You get lots of knowledge, both for your boards and real life. And don't forget to check out our subscription podcast, EM Rapid Bombs. You can check it out on our website and follow us on social media, where I do all of my hard work at EM Board Bombs.
Please follow EM Board Bombs so that Marlena keeps her job. Just kidding.
Yeah. I like it here.
Yes, she needs to eat dinner. Being an emergency doctor isn't enough.
Yeah, right.
Anyway. Yeah, for each 15-minute episode, as Marlena said, hashtag EM Life, hashtag Board Prep. We do it all. Hey, what's coming up in 3 weeks? Aren't you glad you don't have to do this anymore?
Oh, yeah. It's nice. The first year that I'm not having to do this thing, the in-training exam, but all you residents out there, good luck on that. And if you listen to us regularly, you aren't having to cram, hopefully, because you're just so prepared already.
Strip learning.
Awesome. Mm-hmm.
I had to mute my mic there. I just took a sip from a unidentified seltzer. We're not sponsored by them, so I can't mention them by name. But if they're interested and they're watching on YouTube, you can approach us. Have to give a shout out to our only sponsor, EM News. Hey, let's dive in. No prep time. We're not telling you what this question is about, even though the title of the episode will tell you. A patient presents to the ER after receiving a call from their primary care doctor's office that they had an abnormal lab. Classic presentation, right? They tell you that they were supposed to come in yesterday, but they couldn't miss last night's Grammys Awards because they had to know if Beyonce was finally going to win Album of the Year. When you try to ask what kind of labs they had drawn or any other useful information that might help you determine what this abnormal lab might be, this is so funny. It's so true. They say, she won because she had her best album 2 albums ago, and that's how it always works. Sabrina Carpenter, I don't know who that is, will probably win in 2027. While the patient begins serenading you with their best rendition of Texas Hold'em, also never heard that song, you pull up their chart and see that the patient had a positive interferon gamma release assay on some pre-employment labs. If you don't know what that is, then you're going to get this question wrong. In the U.S., what is the most common presenting complaint of someone with primary tuberculosis? Is it choice A, exposure to someone in the same household with active tuberculosis? Choice B, night sweats. Choice C, cavitary lesion on chest imaging. Choice D, palpable cervical lymphadenopathy. What do you think, Dr. Wisiski-kun? So many questions I have. Sabrina Carpenter, Texas Hold'em.
I think
interferon
Dr.
gamma release. I'm just kidding. I know that.
Needs to get more in touch with pop music.
Yeah,
but
whatever.
Secondarily, the correct answer choice here is A, exposure to someone in the same household with active TB.
Perfect. I'll stick with my jazz. I'm perfectly satisfied with my jazz serenades every evening when I'm working on stuff. Yes, perfect. So choice A, exposure to someone in the same household with active TB. That is awesome. What a great, interesting question. What a weird one. So we're talking about TB here. But first, we mentioned the ITE. Why is that important? Why do we care?
Because ITE is board prep, and
that's right.
Board prep is what we do here.
That's right. We offer something more than just the main podcast. which
That's
is
right.
EM Rapid Bombs. For what, just 2 to 4 minutes a day, pretty much? You can prep for your ITE. Got a lot of residents signing up recently. Really awesome stuff, thanks to Marlena's hard work on socials, the YouTubes, everything. So check us out everywhere. You can see our lovely faces on YouTube right now. Got so many referrals from YouTube recently. It's amazing. Check us out. But yeah, we have the Rapid Bombs podcast, 485 episodes or something like that?
Yeah, tons. More than an episode every day between
Yes.
now and next year's ITE.
That's crazy to think about, actually. I did not think of it that way. All right, let's dive into this. So talk about TB. Talk about tuberculosis.
Yeah, so TB is caused by the acid-fast bacillus Mycobacterium tuberculosis, which is simple enough, but what's not simple is diagnosing TB in the emergency department. So even with the recent outbreak in Kansas City, which is timely, which made me think of recording this episode, TB is really rare in the United States, luckily, but it's not rare worldwide. But we don't really regularly think about it here in the United States in our differential, and it's really highly variable in terms of its presentation. So primary TB, which is what the question stem was about, is a TB infection that causes a granuloma formation in a lymph node, and it's usually asymptomatic. So that's why night sweats was not the right answer. When we talked about this earlier, Dr. Briggs and I, about why night sweats is really never the right answer for anything.
It's like the most non-red flag red flag ever.
Yeah.
That's my view on it. How many patients tell you that they
have night
sweats. Having chills and night sweats, and you're like, well, your flu test is positive.
Yeah, exactly.
But if they just went to India, probably a big deal.
Right. Yeah. So we'll actually talk about that later. The culture, the acid fast culture, it takes several days to weeks. So you're really not going to be doing that or talking about it or anything in the ED. So little throwback to med school. Remember, in the lung, the calcified hilar lymph node is called a gone.
I say gone, but
Gone.
I'm sure we'll have someone correct us.
GHON is how it's spelled.
Yes. Gahone.
Gahone complex. Probably not going to be on your chest, but
probably not the right way to say it.
This is a blue collar podcast. Okay, I'm not a pathologist. I don't know.
No, not at all.
So we don't have rapid testing in the ED, but that doesn't mean you're not going to get asked about PPD tests on the test. And if you're a Rapid Bombs subscriber, you actually may have listened to an episode about PPD tests, but we're not going to go into that here. Yeah, but you can listen to a Rapid Bomb episode about it. Just know that in anybody that you're worried about new or reactivation TB, you're going to be admitting that patient to the hospital.
Absolutely. That's just a no-brainer. Even if they look fine, they're texting on their phone, doesn't matter. They're going to go to an isolation room. You're going to alert the health department, and they're going to be admitted upstairs. So talk about the signs and symptoms of reactivation TB, because I feel like this is something that really comes up more, because I feel like they're more symptomatic with reactivation TB versus primary.
Right. So those patients can present with most commonly pulmonary manifestations or systemic. I liked this, that UpToDate tells you this amazing sage advice, which is the key to early diagnosis is to just consider the disease.
That is by far my biggest pet peeve. If I can get on my soapbox, when I read case reports, I read anything in journals, like the clinical photo ones, the rare cases, whatever they put, I read them just because they're interesting. Sometimes the photos are cool looking. And at the bottom of like the conclusion of these cases, it's always like, high suspicion level is important to catching whatever the name of this thing is I've never heard of. And it's like, okay, sure, I'll be guaranteed to think about this one when I think of, 10,000 chest pain patients that come in, every day. So what are the common presenting symptoms, though?
Yeah,
I guess looking into that.
The common presenting symptoms
Yes.
are fever, productive cough, dyspnea, night sweats, malaise, fatigue, weight loss, hemoptysis, and pleuritic chest pain.
So essentially like lung cancer.
Yeah. So like really not that helpful in isolation. And if you saw it, you'd probably say like, oh, you have the flu.
Right.
Honestly, like right now. But if you have a constellation of those symptoms, any collection of them, plus one of the major risk factors. So worth asking these patients about their risk factors being incarceration. Are they foreign-born patients? If, like here in the US, especially, is this a foreign-born patient from an endemic area, or did they recently travel to an endemic area, or do they live with someone who is from an endemic area? So that's, what was important in our question stem. Are they living with someone who just moved here from an endemic area and does have TB? Or is it someone who's immunocompromised? And that's definitely an important risk factor, is being immunocompromised. I think on the test, they often use patients that have HIV and also have TB.
Perfect. Yeah, because endemically, if they haven't traveled, that's going to be the most common population for sure. One thing that's really important here that I know you're about to touch on is the fact that cough is obviously not always a guaranteed symptom.
Right.
So just the absence of cough alone doesn't rule out the possibility of TB. There's one study that is often quoted here that found that cough is only present in like 60-something% of patients. So it's not even like 90%. It's like 6 out of 10. It's almost half. Yeah. And the chief complaint is less than 20. So in general, the physical exam signs are very nonspecific, and this is a very difficult diagnosis to make or to exclude. So anytime you're just concerned, it's not automatic admission for sure. Isolation, precautions, everything.
Right. And classically, we learn about the chest x-ray showing a cavitary lesion in the upper lobe of the lung, the like apical cavitary lesion. Remember that that's in reactivation TB, and that's why it was the wrong answer for this question where we were talking about primary TB. Also, in reality, in tuberculosis, like most other things that we learn about with a classic x-ray finding, this actually can cause a ton of different abnormalities on x-ray, including any infiltrates in any part of the lung. The hilar lymphadenopathy is going to be more reliable, but again, you can pretty much find any kind of chest x-ray finding there.
Yeah. So talk about the test, because I feel like they're going to have to make this a little bit easy.
Yeah.
On
so
IT or your boards.
Right. Luckily, like on the test, they're going to have to kind of throw you a bone here because it's not that common or expected in the United States. So any patient with the cough, night sweats, chills, and fever, you're going to have to consider TB with malignancy. And on the test, they're going to give you one of those risk factors. So they're going to mention the travel to the endemic area or the patient being immunocompromised or having that known contact. So in anyone who you're concerned about TB, admit them to the hospital. And another tip here is another common test question is because this spreads through aerosolization, they may ask you the next first best step, and it's going to be put that patient in the appropriate isolation precautions if they have not already been put in airborne precautions.
This is absolutely going to be a multiple choice question. It'll be like, hey, you suspect TB, what's the next step? And sometimes the answer choices are like isonize it or like get a CT or put the patient on oxygen. And it's like if they're not in extremis, the answer is obviously put them in isolation room. Like forget everything else. Hey, there's a lot more to know about TB that can be on the test. It sounds like if especially those listening, like, hey, what about the isoniazid? What about the seizures on isoniazid? The weird overdoses you get? What about the lymphadenopathy? When do I see that? Whatever, extrapulmonary TB, miliary TB. Yeah, there's importance about those specifics on the stages of the disease, the extrapulmonary manifestations, the treatments. However, we cover literally all of this in less than 4-minute episodes on our Rapid Bombs. You can try it by going to our website, emboardbombs.com. And there you can see so many episodes, like more than 10 episodes, just covering all these specifics of TB that you'll never miss on the test. We cover every angle that you could possibly be tested on tuberculosis. Also just good information to know, especially working in a quote-unquote higher risk area that you could see this more, big population centers, that sort of thing. You can also learn about this cool thing called scrofula, or whatever you called it. How do you pronounce it? Scrofula. That's probably the right way. Also called, quote, the king's evil. Hashtag nerd alert. Check it out on one of our Rapid Bomb episodes. So
I want to round out the episode with a final nerdy music fact. Do you know which one of the Beatles had tuberculosis in childhood?
I have absolutely no clue.
It was Ringo, the drummer.
I'll have to ask it at work and see if the average person will get that. If that's not just a... Did you learn that already? You already knew that?
No, my dad told me.
Oh, that's fascinating.
I know.
Interesting. You know, speaking of rounding things out, I was thinking about listening to this episode as I was listening to you talk about rapid test. What would be the one rapid test for any condition, let's say, and you could do a rapid, it has to be a lab test, obviously, diagnosed by lab, and you could have a rapid lab test. So TB can be one of them. I'm assuming that you wouldn't pick that because that's not that common. I already have mine in my head. I already know what I would want to rapidly test. Like, you have the answer and it's accurate. It's like a rapid strep test, but very accurate, very sensitive.
For like any condition?
Pretty much, within reason. Hopefully our listeners are brainstorming. They may already know.
That's really hard to ask me, like right off the bat.
There's a lot of things, right? Every emergency doctor is like, I wish I had.
I mean, like, dissection would be nice, but
yeah,
that stresses me out.
Okay, I'm sorry. I didn't mean to stress you out. All right, well...
What's yours?
We'll pause that until next episode. What?
What will you tell me yours?
100% gonorrhea chlamydia.
Oh.
That'd be so... you know how much time that would save and antibiotics that would save?
Oh, I guess that's true.
I hear rumors or talks that there is a rapid test somewhere out there, but those people work at Ivy Leagues, so where money is no problem.
Yeah.
It's probably a lot of money. Anyway. All right. Fun stuff. Hey, we got exciting things coming. I know everybody's like listening, rolling their eyes. Really, we do. In like less than 3 months from now, get exciting things. Yeah. We're unveiling. So
it's the final countdown.
Crazy things. So keep an eye out. But otherwise, we'll see you next week for Ian Board Bombs. Thanks for listening.